I'm Samantha Mitchell, 34, and I own one of the most successful hospitals in Boston. Not that you'd know it by looking at me. I still drive my 10-year-old Toyota and wear simple clothes most days. That's why when I walked into the prestigious Bennett Medical Group seeking treatment for migraines, Doctors Harrison and Patricia Bennett assumed I couldn't afford their care. They actually suggested I try the community clinic down the street instead. Little did they know, I own the hospital where they were desperately seeking privileges. Before I dive into how I turned the tables on these status-obsessed doctors, let me know where you're watching from in the comments, and hit that subscribe button if you enjoy stories about sweet, well-deserved comeuppance. I didn't grow up with silver spoons or trust funds. My childhood home was a modest 2-bedroom apartment in South Boston where my parents worked themselves to the bone to keep us afloat. Dad was a janitor at the local high school, working overtime whenever possible. Mom waited tables at 3 different diners, often coming home with swollen feet but never complaining. They sacrificed everything so I could have opportunities they never had. Books were my escape. While other kids played with expensive toys, I devoured medical journals from the public library. My fascination with medicine wasn't random. When I was 9, my grandfather died from complications of untreated diabetes. The image of him refusing doctor visits because it costs too much haunted me. I remember sitting at his funeral, making a silent promise that I would become a doctor who treated everyone, regardless of their bank account. School became my sanctuary. I stayed late to use the computers since we couldn't afford one at home. Science teachers noticed my potential and took me under their wings, providing extra resources and encouragement. By senior year, I graduated valedictorian, earning a full scholarship to Boston University. College was the first time I truly faced the ugly side of classism. While my roommates shopped for designer clothes, I worked part-time jobs between classes. During study groups, I'd hear snide remarks about my secondhand textbooks or worn shoes. One particularly cutting comment came during our anatomy lab when a classmate suggested I must feel at home dissecting because my clothes looked like they came from a donation bin. Rather than breaking me, these experiences strengthened my resolve. I graduated summa cum laude, securing a spot at Harvard Medical School with another scholarship. The prestigious halls of Harvard brought both incredible opportunities and more painful reminders of the socioeconomic divide in medicine. During my second year of medical school, I experienced something that would forever change my perspective. I developed severe abdominal pain and reluctantly visited an upscale hospital near campus. Dressed in my usual worn jeans and faded sweater, I was repeatedly overlooked in the waiting room. When finally seen, the doctor barely made eye contact, rushing through the examination and dismissing my concerns with a prescription for antacid. 2 days later, I was admitted to a different hospital with a ruptured appendix. That experience crystallized everything wrong with healthcare inequality. The doctor who misdiagnosed me didn't see a medical student with perfect grades, he saw shabby clothes and assumed I wasn't worth his time. I vowed then that if I ever had the power to change things, I would create a medical environment where everyone received equal care regardless of appearance or status. My turning point came during my 3rd year when I met Dr. Elizabeth Warren, a brilliant surgeon who became my mentor. Unlike many of her colleagues, she treated every patient from homeless individuals to corporate executives with the same exceptional care and respect. Medicine isn't just science, Samantha, she told me during a late-night surgery. It's humanity. The moment we start judging who deserves our best based on their clothes or connections, we've failed as healers. Dr. Warren saw my potential beyond clinical skills. She noticed my interest in hospital systems and healthcare management, encouraging me to pursue a dual MBA/MD program. You have the heart of a healer and the mind of an innovator, she said. That combination could transform how healthcare is delivered. With her recommendation, I was accepted into the dual degree program, studying business principles alongside medicine. While my classmates planned careers at prestigious private practices, I developed a vision for accessible, high-quality healthcare that didn't discriminate based on socioeconomic status. By graduation, I had more than a medical degree. I had a mission to change the system from within. The path from idealistic graduate to hospital owner wasn't straightforward or easy. After completing my residency in internal medicine, I worked at a community health center in one of Boston's underserved neighborhoods. The pay was modest compared to what my classmates earned in private practice, but the experience was invaluable. I witnessed firsthand how socioeconomic factors impacted healthcare outcomes and learned to provide quality care with limited resources. During this time, I continued developing my business acumen. I took evening courses in healthcare management and spent weekends researching innovative hospital models around the world. My apartment became a war room of charts, business plans, and medical journals. My personal life took a backseat to my ambition, but I remained focused on the bigger picture. My breakthrough came unexpectedly. A research paper I published on cost-effective quality improvement measures caught the attention of Jacob Reynolds, a healthcare investor with a similar vision for accessible care. After several meetings discussing my ideas, he offered to back my first venture, a small consulting firm specializing in hospital efficiency without sacrificing quality. Most consultants cut corners to save money, I explained during our first client meeting. We find ways to eliminate waste while improving patient outcomes. The approach worked. Within 2 years, my firm had contracts with 6 hospitals across Massachusetts. Each success story strengthened our reputation, and soon we were fielding calls from healthcare systems nationwide. I reinvested most profits into expanding our services, hiring talented analysts who shared my vision. I lived modestly despite a growing success. My colleagues purchased luxury cars and down-on condos, but I maintained my simple lifestyle. I upgraded to a small house in a middle-class neighborhood and continued driving my reliable Toyota. This wasn't about being frugal, that was about staying connected to my purpose. How could I advocate for accessible healthcare while surrounding myself with extravagance? The real game changer came 5 years into my consulting career. Riverside Medical Center, a once prestigious hospital that had fallen into financial trouble, was seeking new management. Their board approached our firm initially for consulting, but after reviewing their situation, I saw a bigger opportunity. This isn't just about cutting costs, I told my partners. Riverside could be transformed into a model for what healthcare should be: excellent medical care that's accessible to everyone. With support from Jacob and a consortium of investors who believed in our vision, I made an offer to acquire Riverside outright. After tense negotiations and sleepless nights, we closed the deal. At 32 years old, I became the youngest hospital owner in Boston's history. The transformation of Riverside became my obsession. We overhauled outdated systems, recruited talented medical staff who shared our philosophy, and implemented innovative programs that balanced quality with accessibility. I worked alongside doctors and nurses, understanding their challenges firsthand rather than dictating changes from a corner office. One of my proudest innovations was our sliding scale payment system. Unlike traditional hospitals that provided different levels of care based on insurance, Riverside offered the same exceptional service to everyone, with payment plans tailored to financial circumstances. We expanded our community outreach, established prevention programs in underserved areas, and created pathways for promising students from disadvantaged backgrounds to pursue medical careers. Within 2 years, Riverside's reputation soared. We received national recognition for our innovative approach, and our patient satisfaction scores ranked among the highest in the region. Financial publications marveled at how we maintained profitability while serving diverse populations. Medical schools requested to send their students to learn our model. Throughout this success, I maintained my low profile. Few patients realized the woman occasionally helping nurses change bedsheets was actually the hospital's owner. I avoided industry galas and rarely gave interviews, preferring to let our results speak for themselves. The handful of photos published in healthcare journals showed me in simple professional attire, nothing that signaled my growing wealth or influence. This wasn't just personal preference, it was strategic. By moving through the healthcare world without the trappings of wealth, I gained unfiltered insights that most executives missed. I saw how staff treated different patients, noticed when corners were cut, and identified problems that would never appear in official reports. My management team embraced my core values: meritocracy, compassion, and equal treatment. We promoted based on performance rather than connections, celebrated staff who went above and beyond for patients regardless of their status, and created a culture where everyone from janitors to surgeons felt valued. Healthcare isn't a luxury product, became our unofficial motto. It's a human right delivered with excellence. By my 34th birthday, my healthcare management company had expanded to include 3 hospitals and a network of clinics. Industry insiders knew of my success, but to the general public, I remained largely anonymous, exactly how I preferred it. which is why what happened next caught me completely off guard. The migraine started like a whisper, a subtle pressure behind my right eye that I initially dismissed. After 3 days of escalating pain, light sensitivity, and nausea, I reluctantly acknowledged I needed medical attention. As someone who treats patients rather than receives treatment, I despise being on the other side of the stethoscope. But even hospital owners aren't immune to health problems. I could have easily called one of Riverside's top neurologists, who would have seen me immediately. But that wasn't my style. I believed in experiencing health care as my patients did, without special treatment or cutting lines. Besides, I wanted to consult with a migraine specialist not affiliated with my hospitals to avoid any conflict of interest. Research led me to the Bennett Medical Group, a private practice with sterling medical credentials and glowing reviews from patients. Dr. Harrison Bennett was a nationally renowned neurologist specializing in migraines, while his wife Dr. Patricia Bennett was an equally accomplished internist. Their practice in Boston's affluent Beacon Hill neighborhood served some of the city's most elite patients. I made an appointment for a Tuesday afternoon, intentionally choosing to go alone and dressed in my everyday clothes: jeans, a simple blouse, and minimal makeup. I drove myself in my 10-year-old Toyota, parking between a Mercedes and a Porsche in their private lot. The moment I stepped into their waiting room, I understood the type of practice they ran. The space resembled a luxury hotel lobby more than a medical office, with original artwork, designer furniture, and soft classical music playing through hidden speakers. A marble reception desk staffed by 2 immaculately dressed women completed the picture of exclusivity. I approached the desk, giving my name and appointment time. The receptionist's eyes flickered over my casual attire, her smile dimming slightly as she handed me a clipboard with forms. Dr. Bennett requires comprehensive information from new patients, she explained. Please fill everything out completely. The standard medical history forms were accompanied by additional pages inquiring about my occupation, annual income range, home ownership status, and even where I had attended college. One section asked for personal references within the medical community, essentially checking if I knew the right people. As I completed the forms, I noticed other patients arriving. Each was greeted with warm familiarity by the staff, offered espresso or sparkling water, and escorted to plush seating. No clipboards for them, they were established patients who had already passed whatever screening process I was now undergoing. After returning the forms, I waited nearly 40 minutes despite having arrived exactly on time. Finally, instead of being called to an exam room, I was escorted to a small office where a woman introduced herself as the practice manager. Miss Mitchell, she began, glancing at my forms, before you see Dr. Bennett, I need to clarify a few details about your visit today. What followed was essentially a financial screening disguised as administrative procedure. She explained their practice did not accept most insurance plans and required substantial deposits for new patients. When I mentioned I would pay out of pocket, she seemed skeptical, especially after noting my listed occupation simply as healthcare management without company details. Our specialists are in high demand, she explained with practice diplomacy. Dr. Bennett's expertise attracts patients from around the world, many who have complex cases requiring his particular skills. Translation: they were trying to determine if I was worth their time. I understand, I replied calmly. I'm experiencing severe migraines that haven't responded to over-the-counter treatments. Based on my research, Dr. Bennett's approach to migraine management is exactly what I'm looking for. She smiled tightly, making a few notes in my file before excusing herself. Through the partially open door, I could see her speaking with a tall, distinguished-looking man who glanced at me briefly before shaking his head. 5 minutes later, the man entered the office, followed by an elegant woman. Both wore white coats with their names embroidered in script, Dr. Harrison Bennett and Dr. Patricia Bennett. Miss Mitchell, Dr. Harrison began without offering his hand. I've reviewed your intake information. Unfortunately, I don't believe our practice is the right fit for your situation. I maintained a neutral expression. May I ask why? I'm experiencing debilitating migraines and was referred to you as the best specialist in the area. Dr. Patricia stepped forward with what she probably thought was a compassionate smile. Our practice maintains a certain standard of care that requires significant investment. Given your... She paused, eyes flicking to my simple wash and unmanicured hands. Current circumstances, we feel you might be better served elsewhere. You mean because I appear to not be wealthy enough? I asked directly. Dr. Harrison's expression hardened. We make no apologies for catering to a select clientele. our patients expect a certain environment and level of service that comes at a premium. The community clinic on Albany Street has several competent neurologists who accept all insurance plans and sliding scale payments. I stood, maintaining my dignity despite the humiliation burning in my chest. Thank you for your candor, Dr. Bennett. It's illuminating to see how you evaluate who deserves your medical expertise. It's not about deserving, Dr. Patricia interjected, seemingly uncomfortable with my framing. It's about appropriate allocation of specialized resources. I nodded, gathering my purse. Of course, thank you for your time. As I walked through the waiting room, past patients who had been deemed worthy of the Bennett's care, I maintained perfect composure. Only when I reached my car did I allow myself to feel the full impact of what had just happened. It wasn't that I needed their validation or even their medical care. I had access to dozens of equally qualified specialists. What stung was the reminder that despite all my work to change healthcare culture, practices like the Bennetts continued to thrive by treating medicine as a luxury product rather than a human right. I sat in my car, my migraine pulsing in rhythm with my anger. I could have easily returned, revealed my identity, and watched their faces transform with horror at their mistake. But that would be a momentary satisfaction without meaningful change. Instead, I started my car and drove back to Riverside, an idea already forming. The Bennetts had made a critical error in judgment based on appearances, and as fate would have it, I was in a unique position to turn their mistake into a valuable lesson. The next morning, despite my lingering migraine treated by one of Riverside's neurologists, I began researching the Bennett medical group more thoroughly. What I had experienced firsthand deserved deeper investigation. If they were treating me this way, how many others had been dismissed based on perceived financial status? I signed Rachel Goldstein, our hospital's most meticulous compliance officer, to gather information discreetly. I'm not looking to create a scandal, I explain. I want factual, documented information about their practice patterns and patient selection criteria. Meanwhile, I reached out to my network of healthcare professionals across Boston. Without revealing my personal experience, I casually inquired about referrals to and from the Bennett's practice. The pattern that emerged confirmed my suspicions. They accepted only patients from affluent backgrounds or with powerful connections, regularly redirecting others to more appropriate facilities. They're brilliant physicians, admitted Dr. Marcus Chen, a former classmate who now ran a community clinic. Harrison revolutionized migraine treatment protocols, and Patricia's diagnostic skills are exceptional. But their practice is essentially a medical country club. They once returned a referral I sent because the patient was a public school teacher who couldn't afford their fees. Over the next week, Rachel compiled a comprehensive report. The Bennett's practice served fewer than 300 patients, most from Boston's wealthiest families, along with celebrities and executives. Their fees were among the highest in the country, with annual membership requirements on top of treatment costs. They accepted no Medicare or Medicaid patients and required full payment at time of service. They're not breaking any laws, Rachel noted. Private physicians can select their patients. But ethically, she trailed off, her expression saying everything. What surprised me most was finding several former patients willing to speak about their experiences. Most had been satisfied with the exceptional care. Few could afford their services. The Bennetts were indeed excellent physicians. But I also found individuals who, like me, had been turned away after being deemed financially unsuitable. I inherited my mother's migraine condition, explained Eliza Washington, a school administrator. I saved for months to afford a consultation with Dr. Bennett, only to be told their practice wasn't accepting new patients from my demographic. They didn't even examine me. The most interesting discovery came when Rachel uncovered the Bennett's expansion plans. They were seeking to grow their practice by establishing direct hospital admission privileges at a major medical center, specifically at Riverside. Their application had been submitted the previous month and was scheduled for board review in 2 weeks. They want the prestige of hospital affiliation without the requirements of treating diverse patients, Rachel observed. Having direct admission privileges would let them bypass the normal emergency department channels. I spent an evening reviewing their application materials. Their credentials were indeed impressive: Harvard Medical School graduates, multiple published research papers, and innovations in their respective fields. From a purely medical standpoint, they would be valuable additions to any hospital. But healthcare isn't just about medical expertise. It's about who receives the expertise and how patients are treated as human beings. The Bennett's selective approach directly contradicted Riverside's mission of accessible excellence. I pulled up the recording of my monthly address to hospital staff from the previous year. At Riverside, we judge success not by how well we treat our most privileged patients, but by how we treat those without privilege. Everyone who comes through our doors deserves our best, regardless of their appearance, background, or ability to pay. The irony wasn't lost on me. The Bennetts needed something from me now: hospital privileges that would enhance their practice's prestige and allow them to expand their exclusive services. They just didn't know it was me they needed it from. I faced an ethical dilemma. I could simply reject their application based on my personal experience, but that would be using my position for personal revenge, something I'd vowed never to do. On the other hand, approving physicians who fundamentally opposed our hospital's values would be a disservice to our mission. I called Dr. Elizabeth Warren, my mentor who now served as chief of medicine at Massachusetts General Hospital. Without naming the Bennetts directly, I outlined the situation. "You have an opportunity here," she said after listening carefully. "Not for petty revenge, but for meaningful change. The question isn't whether to approve or deny their application, it's how to use this situation to advance your mission of healthcare equity." Her words crystallized my approach. This wasn't about embarrassing the Bennetts or denying them privileges out of spite. It was about creating accountability and potentially changing their perspective. If they wanted the benefits of association with Riverside, they would need to embrace our core values not just in words, but in practice. I instructed our board secretary to schedule the Bennetts' interview for the upcoming board meeting. Then I prepared a proposal that would challenge them to grow beyond their exclusive model while still respecting their autonomy as physicians. The night before the board meeting, I reviewed my notes one final time, considering all possible outcomes. This confrontation wasn't one I had sought, but perhaps it was necessary not just for the Bennetts and me, but for the larger principle of what healthcare should be. Riverside's boardroom projected quiet authority without ostentation. The long chairwood table and comfortable leather chairs spoke of quality, while framed photographs of our community outreach programs lining the walls reminded everyone of our mission. Board meetings typically began promptly at 9:00 a.m., but I had arranged for the Bennetts' interview to be scheduled for 9:30, allowing time for regular business first. From my office, I watched on the security monitor as the Bennetts arrived at 9:15, 15 minutes early, a power move I recognized from countless business negotiations. Dr. Harrison wore an impeccably tailored suit that probably cost more than what many of our nurses earn in a month. Dr. Patricia complimented him in a designer dress and pearls. They carried leather portfolios and exuded the confident air of people accustomed to getting what they wanted. The receptionist informed them the board chair was running slightly late and offered to escort them to the waiting area. I observed Harrison's momentary frown at this deviation from his timeline. First lesson in humility. Sometimes even important people must wait. At 9:40, I texted our board secretary to begin without me. The Bennetts would be invited in first to make their presentation, with board questions to follow. I would make my late entrance during the question period for maximum impact. Through the executive conference line, I listened as they were escorted in and introduced to the board. Dr. Harrison immediately took control of the room with practiced charm. "Distinguished board members, thank you for considering our application for hospital privileges at your fine institution," he began. "The Bennett Medical Group represents the pinnacle of neurological and internal medicine care in New England. Our patients include innovators, leaders, and visionaries who demand and deserve the absolute best in healthcare." For the next 15 minutes, he detailed their impressive credentials, research contributions, and exclusive approach to patient care. Dr. Patricia occasionally added polished comments emphasizing their commitment to unparalleled medical excellence. "Our patients expect seamless care," Harrison continued. "Direct admission privileges at Riverside would allow us to extend our boutique medical experience into the hospital setting when necessary, ensuring our select clientele receive consistent quality throughout their healthcare journey." The phrase "select clientele" was my cue. I gathered my materials and headed toward the boardroom, listening through my earpiece as Dr. Margaret Acaffer, our chief of neurology, asked the first question. "Your medical credentials are certainly impressive," she acknowledged. "However, Riverside serves a diverse community. Could you explain how your practice's exclusive model aligns with our mission of accessible excellence? Harrison responded smoothly, we believe in stratified excellence. Our model allows us to focus intensive resources on patients who can truly benefit from and appreciate our approach. This concentration of excellence raises standards across the healthcare ecosystem. In practical terms, Patricia added, we serve those who drive medical innovation forward through their influence and resources. The advancements we pioneer eventually benefit patients at all levels. The classic trickle-down healthcare argument. I'd heard it many times from physicians who preferred wealthy patients but wanted to believe they were still serving the greater good. I entered the boardroom quietly as Dr. James Rivera, our chief of emergency medicine, asked, what percentage of your current patients are on Medicare, Medicaid, or sliding scale payment plans? Harrison shifted uncomfortably. Our practice is designed for a particular demographic. We don't participate in government insurance programs as they don't adequately compensate for our level of service. So 0%, Dr. Rivera clarified. We make contributions to community clinics instead, Patricia offered quickly. I chose this moment to walk to the head of the table. I apologize for my tardiness. Traffic was unexpectedly heavy this morning. The board members nodded in acknowledgement, but my focus was on the Bennetts. Harrison's expression shifted from polite deference to confusion as he tried to place my face. Patricia was quicker, her eyes widened with recognition, and she placed a warning hand on her husband's arm. Please continue, I said, taking my seat. I believe Dr. Bennett was explaining their practice's approach to serving diverse populations. Harrison recovered quickly, though his confident smile had diminished. As I was saying, our practice focuses on a specific segment of patients who can afford your fees, I finished for him. Dr. Bennett, would you say your medical expertise should be available only to those with financial means, or do all patients deserve access to quality care regardless of their socioeconomic status? His eyes narrowed slightly. Ideally, all patients deserve quality care, but practical realities require certain economic models to sustain premium services. Interesting perspective, I replied. You mentioned your practice serves, and I quote, patients who can truly benefit from and appreciate your approach. Could you clarify what factors determine a patient's ability to truly benefit from migraine treatment? The trap was set. If he claimed wealthy patients had greater medical need, he'd sound ridiculous. If he admitted to pure financial screening, he'd contradict medical ethics. Harrison chose a diplomatic middle ground. We consider multiple factors including treatment compliance history, lifestyle stability, and ability to follow through with comprehensive care plans. All of which you determine how, I pressed. Through our initial consultation process, Patricia interjected, we have a thorough screening that helps identify patients who will thrive under our care model. A screening that includes questions about income, home ownership, and personal connections within the medical community, I noted, but interestingly, not questions about severity of symptoms or impact on quality of life. The atmosphere in the room shifted as board members began connecting the dots. Harrison's expression hardened as he finally placed me. You were in our office last week, he stated flatly. I nodded. I was experiencing severe migraines and sought treatment from Boston's supposed best specialist. I was turned away before any medical evaluation because, based on my appearance and apparent financial status, I was deemed unsuitable for your care. Patricia's face flushed. There was a misunderstanding. There was a judgment, I corrected firmly. A judgment that someone in jeans and a simple blouse, driving a Toyota, couldn't possibly afford or deserve your medical expertise. You suggested I try the community clinic on Albany Street instead. The boardroom fell silent. Several board members exchanged uncomfortable glances. For those who haven't connected the dots yet, I continued, addressing the board rather than the Bennetts, I am Samantha Mitchell. In addition to chairing this board, I founded and own Riverside Medical Center. The hospital privileges Drs. Bennett are seeking would be granted by the institution I built, an institution founded on the principle that excellent healthcare should be accessible to everyone, not just those who look the part of wealth. Harrison's face had gone from flushed to pale. This is completely unprofessional. You deliberately misrepresented yourself to set us up for this public ambush. I represented myself as a patient seeking medical care, I responded calmly. I didn't wear a sign announcing my ownership of a hospital network because patients shouldn't need power or status to receive respectful treatment and appropriate care. The fact that you view this as a setup rather than a failure of your practice's values speaks volumes. Patricia, to her credit, seemed genuinely mortified. Miss Mitchell, I apologize for how you were treated. Our approach was clearly misaligned with your medical needs. Not just my needs, Dr. Bennett. The needs of countless patients you've turned away without medical evaluation because they didn't meet your socioeconomic criteria. I turned to address the entire room. This isn't about me being offended. It's about a fundamental question of what medicine should be and who deserves access to excellent care. The tension in the boardroom was palpable. Harrison Bennett remained rigid, his jaw clenched in barely contained anger. Patricia's expression reflected a more complex mixture of embarrassment and dawning realization. So this is your revenge, Harrison finally asked. Humiliating us in front of your board after deliberately deceiving us. I shook my head. This isn't about revenge, Dr. Bennett. If it were, I would simply reject your application and end this meeting. This is about something much more important. It's about the fundamental values of healthcare. I opened a folder containing printouts of their application materials and my proposal. Your medical credentials are exemplary. Your research contributions significant. From a purely clinical perspective, your affiliation would benefit our hospital. I paused, making eye contact with each of them. However, Riverside was founded on the principle that excellent care should be accessible to all patients, not just the privileged few. Your current practice model directly contradicts this core value. Patricia leaned forward. Miss Mitchell, while I understand your frustration with your personal experience, our practice model allows us to provide unparalleled care to our patients. To some patients, I corrected, to patients who look and spend a certain way. The question is whether that selective approach aligns with what medicine should be. I slid copies of my proposal across the table to them and the board members. I'm not here to reject your application outright. Instead, I'm offering conditional approval with specific requirements that would bring your practice into alignment with our values while respecting your autonomy as physician. Harrison reluctantly took the document, scanning it with narrowed eyes. Patricia read more carefully, her expression gradually shifting from defensive to thoughtful. These conditions are unreasonable, Harrison said, placing the paper down. You're essentially asking us to dismantle our entire practice model. I'm asking you to expand it, I countered. The proposal requires that 20% of your patient load include individuals from diverse socioeconomic backgrounds, with at least half of those receiving care on a sliding scale basis. It also requires quarterly participation in our community outreach programs and mentorship of 2 medical students from disadvantaged backgrounds each year. This would significantly impact our revenue model, Harrison argued. It would, I acknowledge. But I suspect your practice is profitable enough to absorb this change, especially with the prestige and referral network that Riverside affiliation would bring. More importantly, it would restore the fundamental purpose of your medical expertise, helping those in need, not just those who can pay premium rates. Dr. Patricia touched her husband's arm. Harrison, perhaps we should discuss this privately. I nodded. Of course, the board will give you time to consider. Feel free to use the conference room down the hall. As they left, the remaining board members turned to me with expressions ranging from shock to admiration. That was unexpected, Dr. Rivera commented. Was your experience with them as bad as you indicated? Dr. Okafor asked quietly. Every word was true, I confirm, but this isn't about my wounded pride. It's about whether we're willing to grant privileges to physicians whose practice fundamentally contradicts our mission. Could we have simply rejected their application? Asked Thomas Williams, our legal counsel. We could have, I acknowledge. But that wouldn't create change. This approach gives them an opportunity to evolve their thinking and their practice. If they accept, patients who would never have accessed their expertise will benefit. If they refuse, at least we've challenged them to examine their value. After 20 minutes, the Bennetts returned. Patricia spoke first. We've discussed your proposal and have some questions about implementation, she began, surprising Harrison, who seemed prepared for outright rejection. Specifically, how would patient selection work for the diverse population requirement? For the next half, we engaged in substantive discussion about how they could integrate more inclusive practices while maintaining their specialized approach. Harrison gradually moved from resistant to reluctantly engaged, while Patricia showed genuine interest in how sliding scale payments could work without destabilizing their practice. I still believe our original model has merit, Harrison stated. The focused attention we provide requires significant resources. No one is suggesting you can't maintain a premium practice, I replied. The question is whether that premium care should be available only to those with means, or whether medical excellence is something that should be accessible based on need rather than wallet size. Patricia nodded slowly. When I entered medicine, my vision wasn't to serve only the wealthy. Somewhere along the way, exclusivity became equated with quality in our practice. It's a common evolution, I acknowledge. But quality and accessibility aren't mutually exclusive. Riverside proves that every day. After further discussion, the Bennetts requested a week to consider the proposal and develop an implementation plan. I agreed, suggesting we meet privately rather than returning to the full board immediately. Whether you accept our conditions or not, I told them as they prepared to leave, I hope today has prompted reflection on what medicine should be and who deserves access to your considerable talent. Harrison's response was stiff but civil. You've certainly given us something to think about, Miss Mitchell. Patricia lingered after her husband left the room. For what it's worth, I am truly sorry about how we treated you. Seeing you in this context makes our assumptions even more embarrassing. The problem isn't how you treated me, I replied. It's that you would treat anyone that way. I have resources and access most patients don't. Think about those who are turned away and have nowhere else to go. She nodded thoughtfully before following her husband out. 1 week later, we met in my office. The Bennetts arrived with a detailed plan addressing each condition in my proposal. To my surprise, they had gone beyond the minimum requirements, proposing a monthly free clinic for migraine patients without insurance and a research initiative focused on improving migraine treatment accessibility. We've spent the week reevaluating our practice philosophy, Patricia explained. Your challenge forced us to confront the disconnect between why we entered medicine and how we've been practicing it. Harrison was less effusive but sincere. I maintain that our concierge model serves an important segment of patients. However, I can acknowledge that restricting our expertise exclusively to that segment represents a failure of our medical obligation. This isn't about abandoning excellence, I clarified. It's about expanding who has access to that excellence. We spent the next, refining their proposal. By meeting's end, we had a framework that would maintain their practice's high standards while opening doors to patients who would previously have been rejected without evaluation. Conditional privileges approved, I said, signing the necessary documentation. Welcome to Riverside, Drs. Bennett. I look forward to seeing how your practice evolves. As they stood to leave, Patricia asked the question Harrison was clearly thinking. Why did you give us this chance? After how we treated you, you could have simply rejected our application. I considered the question carefully. Because medicine isn't about power or retribution. It's about healing and growth not just for patients, but for the medical community itself. Sometimes the people who need to change their perspective the most are the ones we should engage with rather than dismiss. Harrison extended his hand. A perspective I'm beginning to appreciate, Miss Mitchell. Though I maintain you could have made your point without the dramatic reveal in the boardroom. I shook his hand with a smile. Perhaps, but would it have made the same impression? For the first time that day he smiled back reluctantly but genuinely. Touché, Miss Mitchell, touché. 6 months passed quickly. Spring arrived in Boston, bringing cherry blossoms to the hospital courtyard and new developments in the Bennett saga. I maintained periodic oversight of their integration with Riverside, curious whether their initial commitments would translate into meaningful change or fade into convenient promises forgotten after securing privileges. To my pleasant surprise, Patricia Bennett embraced the transformation wholeheartedly. She restructured their intake process, eliminating financial screening questions and replacing them with more relevant clinical assessments. Their waiting room still featured comfortable furniture and original artwork, but pamphlets about their sliding scale program and community outreach were prominently displayed. Harrison's evolution proved slow but steady. He initially approached their required community clinics with rigid professionalism, maintaining emotional distance from patients who couldn't afford their regular fees. But something shifted during their 3rd month of clinic service when he treated Maria Gonzalez, a restaurant worker suffering from debilitating cluster headache. She reminded me of my mother, he admitted during one of our quarterly review meetings. Same symptoms, same determination to work through the pain because her family depended on her income. My mother had me a doctor's son with access to excellent care. Maria had no one until our clinic program. Under his treatment, Maria's condition improved dramatically. She became the first of many success stories that gradually softened Harrison's perspective on who deserved his expertise. The most significant indicator of genuine change came 4 months after our confrontation. The Bennetts requested a meeting where they proposed establishing a scholarship program for medical students from disadvantaged backgrounds, jointly funded by their practice and Riverside. "We want to address the pipeline problem," Patricia explained, using the healthcare terminology for the lack of diversity in medical practitioners. Excellent care for diverse populations should ideally come from a diverse medical community. I agreed to match their funding, creating 10 full scholarships for promising students from underrepresented communities. We named it the Accessible Excellence Initiative, deliberately avoiding our names to keep the focus on the mission rather than personal recognition. This partnership generated unexpected media attention. The Healthcare Journal requested an interview about our collaboration, which led to a feature story on healthcare equity initiatives. Without revealing the full confrontation that had initiated our partnership, we discussed the importance of reconsidering traditional barriers to quality care. The article resonated throughout Boston's medical community. Several other exclusive practices reached out to discuss similar partnership models. Some were clearly motivated by positive publicity rather than genuine commitment to change, but others showed sincere interest in expanding their services to underserved populations. Dr. Elizabeth Warren, my longtime mentor, called after reading the article. "You didn't just change one practice," she noted. "You're creating a ripple effect throughout the system. This is how institutional change happens, one converted gatekeeper at a time." For me personally, the experience provided powerful lessons about judgment, power, and forgiveness. The initial hurt of being dismissed based on appearances had transformed into something constructive, not just for me, but for countless patients who would now receive care they would otherwise have been denied. I continued my practice of moving through the healthcare system without announcing my position. During one visit to the Bennett Medical Group's community clinic, I observed Harrison spending extra time with an elderly man struggling to understand his treatment plan. There was no audience, no recognition, just a physician providing excellent care to someone who needed it. The transformation appeared genuine. Patricia spotted me as I was leaving. "Checking up on us?" she asked with a knowing smile. "Quality control," I replied lightly, "though I'm pleased to see it's unnecessary." "This experience has been humbling," she admitted. "When we first agreed to your conditions, Harrison viewed it as the cost of doing business with Riverside. Now he blocks Thursday afternoons for the clinic and reschedules his wealthy patients around it rather than the other way around." "And you?" I asked. She considered the question carefully. "I've been thinking about why I became a doctor in the first place. Somewhere along the way, prestige and exclusivity became proxies for excellence. Your challenge forced me to confront that drift from my original purpose." That conversation confirmed what I'd hoped, that genuine change was possible even in a system as entrenched as premium healthcare. The Bennetts hadn't completely abandoned their high-end practice model, but they had expanded their definition of who deserved their expertise. It wasn't perfect, but it was meaningful progress. In my own hospitals, I implemented new training for all staff, emphasizing the importance of treating every patient with equal respect regardless of appearance or background. I shared my experience of being rejected by the Bennetts, now with their permission, as a case study in how implicit biases affect healthcare delivery. "Appearances are unreliable indicators of anything except our own prejudices," I told staff during training sessions. The woman in designer clothes might be in crippling debt, while the man in worn jeans might own the building you're standing in. More importantly, neither deserves better medical care than the other. The scholarship program flourished, with 20 students now receiving full funding for medical school. I made a point of mentoring several personally, sharing my experiences navigating medicine from a non-privileged background. Their fresh perspectives and determination reminded me daily why this work mattered. 1 year after our confrontation, Harrison and Patricia invited me to dinner at their home, a gesture of reconciliation that would have seemed impossible during our boardroom showdown. Their house was exactly what you'd expect from successful physicians: spacious, tastefully decorated, in an exclusive neighborhood. But photos from their community outreach work now held prominent places alongside family portraits. "I wouldn't have believed this transformation possible," Harrison admitted over dinner. "I was convinced our practice model represented the pinnacle of medical care. Your challenge forced me to distinguish between excellence and exclusivity, concepts I had erroneously conflated. The irony, Patricia added, is that our practice is now more fulfilling. Treating patients across the socioeconomic spectrum has made us better physicians. The complex cases we see in the community clinic often require more creative approaches than the straightforward cases that come with excellent insurance. I raised my glass in a toast to growth and learning at any stage of our career. Harrison nodded, and to judging less, healing more. As I drove home that evening, I reflected on the unexpected journey that had unfolded from that initial rejection. What began as a painful reminder of healthcare inequality had catalyzed meaningful change, not through confrontation alone, but through offering a path forward rather than simply pointing out the problem. The most powerful lesson wasn't about exposing the Bennett's bias or wielding my position to force change. It was about the capacity for growth when people are given the opportunity to realign their practices with their deeper values. Harrison and Patricia weren't villains, they were physicians who had gradually drifted from their original purpose and needed a significant challenge to their worldview to find their way back. In my work building accessible healthcare systems, I had always focused on institutional policies and payment models. The Bennett experience reminded me that lasting change also requires addressing the underlying assumptions and values of the individuals within those systems. True transformation happens not when we simply reject those who don't share our vision, but when we engage them in reimagining what's possible. The Bennetts now serve as unexpected allies in the ongoing work of healthcare reform, proof that even the most entrenched perspectives can evolve when challenged with both firmness and respect. As for me, I continue driving my 10-year-old Toyota to work each day, still preferring simple clothes and minimal recognition. Not as a disguise or test, but as a reminder of what matters most, seeing each person for their humanity rather than their appearance, status, or bank account. Have you ever been judged based on appearances only to surprise someone with who you really are? Or have you discovered your own biases about others based on superficial factors? Share your experiences in the comments below. If this story resonated with you, please hit the like button and subscribe for more stories about challenging assumptions and creating positive change. Remember, sometimes the most powerful position isn't the one listed on your business card, it's the example you set through your actions and values every day.